I'm going to present a case again. I really enjoyed the introductions, Sung-Ho, and the case that you presented also, Jae-Young. So I think we're all going to be presenting similar cases of very complex, vessel disease in the distal branch pulmonary artery. So this is another one of those cases. So this is the original diagram that I found for this particular patient born with pulmonary VSD MAPCIS. Now I wasn't involved with this at the very beginning. In fact, I inherited this patient after the initial surgeries. But by the time I took this kid to the cath lab, you can see that there's a suture, sternal wires there. And I took this picture and I was surprised that even though it was supposed to have had unifocalization and RV2PA conduit, there's a large residual collateral that feeds pretty much the entire right lung. You can see how extensive the collaterals are to the right lung. You can see there's a clip there, and when I went through the right heart, I could see that the right ventricle is connected to what appears to be a pretty reasonable left lung here. So, but here you have a separated collateral flow to the right lung and a MPA to LV, RV to left lung connection with a severe stenosis. So this was presented to our surgeon. And so basically the patient ended up going to the, now I'm having trouble advancing my slide. The patient went back to the operating room and they unifocalized the right lung PA collaterals back to the MPA and then did an LPA plasty. Now at that point in time, this is 2.5 months later, I bring the kid back to the cath lab, knowing that a lot of times you can have continuous stenosis of the vessels. These are collaterals, remember. Look how tiny these vessels are. And you can see that at this point in time, all the collaterals are connected to the MPA, but there's severe multi-vessel disease, mostly involving the right lung. So again, we started with angioplasty first. At this point, we thought that this patient basically had what was the lower lobe and the middle lobe. The upper lobe is gone, but you can see how even with angioplasty, you don't have a lot of good results here. Look how small the distal vessel is. The parenchymal blush is very poor. So we know that this lung is not well developed. At this point in time, I thought it was important to add a stent in there so we can get better flow to the lung field. And as Sung-Ho said, we have to have good flow in order to grow the parenchyma, especially as a baby. So we put a stent in and we balloon the middle lobe here, and a lot of aggressive ballooning. But you can see how once you improve the vessel flow, you can see the distal vessels. And so there is definitely parenchymal blush there. So at this point, I know that there's an opportunity for us to grow this lung. We actually end up stenting that as well. So here we have double stenting, one to the middle lobe, one to the lower lobe, and this is what we ended up with. It actually looks pretty good. Now, remember earlier, you couldn't see the subsegmental branches or the very tiny vessels, but now you can see some degree of parenchymal blush. And then now looking at this, you can see that there is still some residual stenosis proximal. So again, here we are. I tend to be very aggressive at trying to establish good flow to the lung. So we stented both the lower lobe and the middle lobe. And at this point in time, I decided to put 2 more stents in proximal to try to get more flow into the right lung. So we are putting double stents in the proximal right. And this is what we ended up with. I was pretty pleased with this at this time. We brought the kid back in 2.5 months later, and this is what we get. You see that there's improved flow to the middle lobe, but you can clearly see that with the residual waste in the stent, it's not surprising to see that there's a lot of intimal proliferation within that waste. And again, the flow has been diminished because of that. Again, we went ahead and further aggressively dilate the lower lobe and try to get it as best as possible to get more flow out there. So this is what we have. And further dilation, and just being very aggressive at opening these vessels. And this is what we ended up with at the final end of this cath.
Can you tell me what kind of balloon do you, high pressure balloon use?
You know, I use all kinds of balloons. It's Dorados. I like to use the Dorados because they can go up to 18 atmospheric pressures. On the larger size, we use the Atlas Gold and the Vita balloons, but usually in the small vessels, the products. Now, one of the things I've learned is that some of these small, if it's a very small vessels, 4 to 5 millimeters, you can actually have some very high pressure coronary balloons as well. And so for the small vessels, you can get away with coronary balloons that can go up to 18 atmospheric pressures as well. So this is the pre and post. You can see that slowly the vessels are going from 1 point something millimeters now to 5 millimeters. But it's interesting that at this size, it's not uncommon to have a good result. But when you bring them back, even though the intimal proliferation inside the stent is small, relatively, it can drop the diameters. So another 2.5 months later, this is cath number 4. You bring them back in, but now it actually looks better. Now we see how there's still some distal stenosis beyond into the lower lobe here. Upper lobe is pretty good now. But so here we've decided that we're going to do more dilations beyond that area. And you can almost see where the balloon, we break the waist with the end of the balloon here. And further dilation on the upper and just more and more of this. And now we're adding another stent right in that spot, just beyond the distal, into this, just before the segmental branches. And now we're improving that flow there. And you can see that sometimes you have to make a calculation where you can jail a segment, but it's a calculation knowing that if I can get more flow to the other segments, even if we lose this, it's still better than nothing. We also know that we can go through the side and go after that, go through the side cell as well. So here we are going, now originally from the intimal inside 1.8 to 4.8 millimeters. Down on the bottom, again, some residual stenosis that we've increased to about 5.6. So you can see that from the original cath, first cath, to the second cath, to the third cath, we're slowly making our way up from very small vessels to something that's more reasonable. And then finally, 19 months later, we bring them back and we further dilate this, but you can see that the vessels are much more developed at that point. The flow is smoother. The bigger they get, the less intimal proliferation you see inside. And so this is just basically over a 28-month period, 4 caths later, you can see that we're slowly increasing the size proximally so we can grow the distal vessels as well. So let me just summarize that rehabilitation of distal branch pulmonary artery stenosis involves multiple tedious caths, including aggressive angioplasty and stenting. Serial caths over a short time during the first few years of life is crucial in order to promote pulmonary vascular growth. And as Sung Ho said, I would say that 80% of your additional pulmonary vascular growth after birth occurs in the first 2 years of life, and the remaining 20% growth happens up to 8 years of age. And it's really important to go after them early on, even though those are the most difficult types of cases. So that's my presentation for the case. Thank you.